next, I call upon Dr. Harsh Mahajan on coronary. Okay, is this coronary CT scan or MRI? What is the choice in 2025?
All right. Good afternoon, everyone. I'm Dr. Shoma, and I'm here in place of Dr. Harsh Mahajan. So today I'll just be walking you through CT coronary angio and MR coronary angio. And at the end of it, maybe you can decide what holds today in 2025. So imaging the heart with both CT and MRI remains challenging because given that the heart has a tendency to move involuntarily, of course, and it has a complex structure. Now, various techniques such as ECG gating and rapid imaging algorithms have evolved over the years, and these have served to mitigate cardiac motion. Similarly, multi-detector CT and in MR, 3D whole heart acquisition, these provide what we call isometric voxels. And with this, we can significantly enhance our capability to provide 3D reconstructions. Now, both cardiac CT and MR, they both remain vital in diagnosing cardiac disease, evaluating post-procedure outcomes, and preventing severe cardiac events. Now, the major concern with CT coronary angio is always radiation dose. Now, advances in technology, especially with our 256 slice scanners or even higher, have significantly reduced radiation exposure compared to older 64 slice CT scanners. And just by doing this, we have brought down the radiation dose by 32%. And further advances like using dual energy CT scan have further brought it down so that a CT coronary angio today exposes a patient to just 2.7 millisievert of radiation as opposed to 40 millisievert that he would get with a traditional thallium scan stress test and approximately 7 millisieverts from your routine diagnostic invasive angiography. Now, coming to one of the biggest frontiers of CT coronary angio, and that is calcium coronary artery calcium score, or what we call the CACS. This basically quantifies coronary calcium using ECG-gated CT scanning without the use of contrast. Now, according to the American Heart Association, a CACS score of 0 suggests withholding statin therapy, and this is despite whatever your lipid profile might be, while a CACS over 100 indicates the initiation of such treatment. For low-risk individuals with CACS of 0, repeat scanning every 5 to 10 years is recommended. And a study on the utility of coronary artery calcium for mortality risk stratification among hypertensive adults, including those who would be eligible for the sprint trial. In this study, they showed that a CACS score of more than 220 identified individuals with cardiovascular mortality rates similar to those observed in the standard treatment arm of the sprint. Now, coming to coronary angio, it has very high negative predictive value, typically over 90%, which means that if your coronary angio is normal, you virtually rule out coronary artery disease. So a negative result means absence of disease. However, when there are positive findings, we often have to push the ball into the cardiologist's court, right? So where is its value? Its value is in assessment of stable chest pain. And this has been shown to reduce likelihood of procedure-related complications compared to invasive coronary angiography. It is also valuable for patients who present with typical, stable, atypical, or anginal symptoms, regardless of their coronary artery disease history. It's also a value in inconclusive cardiac functional tests or in asymptomatic patients at high risk of CAD. However, as a screening tool in asymptomatic or low to intermediate risk patients, this value still remains controversial. So, CCTA is coronary CT angiography guided management of patients with stable chest pain was shown to be associated with a sustained reduction in coronary heart disease. And identification of coronary atherosclerosis by CCTA improved long-term cardiovascular disease prevention in stable chest pain. Now, not only can we evaluate the anatomy, look at stenosis and plaques, but we can also derive fractional flow reserve. Now, how do we derive this? It's basically a computational technique, and it simulates pressure, flow, and fluid dynamics within the coronary arteries. And studies have shown 14% more revascularization in stable chest pain patients compared to traditional myocardial perfusion imaging. So this is basically, we don't need to take any additional sequences. Whatever coronary data is just put through a CT, put through an algorithm or a software, and we can derive the FFR from this. It has proven its utility in evaluating coronary artery conditions in patients with stable angina experiencing recurring chest pain. Now, another thing that coronary CT angio does is that it brings out, or it shows you which plaque is vulnerable or a high risk plaque. And what are the CT characteristics of a high risk plaque? Any plaque that has a low CT attenuation value, that is somewhere in the range of 30 to 60, is a high risk plaque or a vulnerable plaque that has the potential to break away, as compared to plaques with higher CT attenuations, which indicate fibrous or calcified plaques. Fibrous plaques typically have CT densities in the range of 61 and 149, while calcium plaques have it in the range of 150 to 1300 HU. Also, positive remodeling index of more than 1.1. What this means is basically if the arterial wall at the site of the plaque dilates, then this makes the plaque vulnerable or a high-risk plaque. Similarly, in CT, we have what is known as a napkin rim sign. That is, if the plaque has a dense peripheral rim and this surrounds a low attenuation core or a necrotic core surrounded by a fibrous cap. So these are the characteristics of a high risk or a vulnerable plaque, and this is independent of the degree of stenosis. So we write modifiers so that if it's a CAD-RAD2 mild CAD, but if a plaque shows these kind of high risk features, then a modifier is added that high risk plaque. The disease may be mild, but the plaques show high risk features. Now going on to planning coronary revascularization. Now, coronary CT has been shown to aid decision-making in PCI and CABG procedures. There was an RCT study conducted, and the results showed increased rates of successful recanalization when planning CTO PCI using both CCTA and ICA images. And this was more evident in lesions with higher JCTO scores. That is, the more complex the lesions, the more successful was the outcome if both coronary CT and the ICA data were used together. So complex the lesions, the more successful it was. There's also the fast track CABG trial going on, and this trial assesses whether safe and effective planning and executing CABG in multivessel disease can be based on pre-procedural CCTA and FFRCC and replace ICA altogether. And there was also the Syntax 3 Revolution trial, where they assessed clinical decision-making between CABG and PCI based on just CCTA, and they found high agreement with treatment decision based on ICA. Now, what are the steps of a coronary CT-derived PCI? So not only can you see the plaque, you assess the degree of stenosis, you can also find the FFR, and you can even do a virtual PCI. You can even do a virtual PCI and assess the flow rate after doing the PCI. So this is just to talk a little more on virtual coronary intervention. Basically, a virtual FFR is calculated from a 3D data set of CT coronary angiogram, and this is just a computational fluid dynamics modeling, and it obviates the need for invasive pressure via measurements. It predicts invasive measured fractional flow reserve with a very high accuracy. And after that, a virtual coronary VCI, what we call a VCI, is done. This allows you to put a stent over here like that and then calculate the FFR distal to the stent. So this is known as virtual coronary intervention, and this is one step after a CT FFR. Now coming to CMR coronary angio. CMR is the gold standard modality for the measurement of cardiac structure, volume, function, tissue characteristics, and myocardial perfusion. However, it is lagging behind in coronary angiography. And the reasons are that it has a much lower spatial resolution. In CT, you can take 0.4 to 0.6 mm slice thickness, while in MR, you're limited to 1 mm slice thickness. It has a much longer acquisition time. It has a higher cost. It involves much more complex planning, and the image quality is very prone to degradation from both cardiac and respiratory motions. So basically, you have lower sensitivity and specificity as compared to coronary CT angio. So as of now, coronary MR angio is limited to evaluation of coronary anomalies assessing for coronary artery aneurysms, and sometimes for proximal artery assessment. So there are different innovations in CMR technology, and they are trying to overcome it. We have ways to accelerate image. We do motion correction. Reconstruction frameworks are advanced. We have simplified scan panning, higher field strength MRs, 3 Tesla, 5 Tesla. All of these can acquire very accurate and beautiful images of the coronary artery. And this is an image from this article which shows the first row is coronary MR angio images, and the second row is basically CCTA images, and both of them seem almost similar. Also, regarding plaque characterization, MR is able to characterize vulnerable plaques. So all these vulnerable or high-risk plaques have high T1, and so we call them high-intensity plaques or HIP plaques. And this high T1 is basically indicative of some kind of hemorrhage, thrombus, or a lipid core in the plaque, thereby making it a vulnerable plaque. And the best thing about coronary MR angio is that you can do it with or without contrast. So you don't need to give contrast at all. So of course, again, it is limited by respiratory and cardiac motion artifacts. And of course, the study time can be very prolonged and unpredictable. Now, we have to integrate a lot of motion correction techniques, right? So to summarize MR angiography, it is emerging high-performance CMR scanners, which are 3 Tesla and above. These are basically enhanced with AI and sensors, and they can, given in the course of time, come up to CTA quality imaging. And these advancements offer potential benefits of no ionizing radiation and no nephrotoxic contrast agents. Now, new scan techniques like single scan multi-contrast angiography, that is, in one scan, you're able to achieve not only black blood images, but also white blood images. So while the white blood images show you anatomy, the black blood images will show you a vulnerable or a high intensity plaque. I can go back to, so here is an example of a white blood image where you can see the anatomy, and these are black blood images where the vessels appear black, so that a high intensity or a vulnerable plaque will basically shine within this vessel. So coronary CT or MR, what is the choice in 2025? We are still with CT coronary angiography, and MR angiography is catching up, hopefully fast. Thank you so much for your patience.
Thank you, Dr. Shoma Mukherjee, for this excellent lecture.